Namaste. It's 6:30 a.m. in LA and Vancouver, 9:30 a.m. in New York. Good morning to our colleagues in the United States and Canada. It's 1:30 p.m. in London, 2:30 p.m. in Europe. Actually, the time's now changing. Good afternoon to our colleagues in Europe. It's 7 p.m. in India. We don't change our clock. And 9:30 p.m. in Singapore. A good evening to our colleagues in Asia, and it's 12:30 a.m., well past bedtime for our colleagues in Australia who join nonetheless. A warm welcome to our colleagues. I'm Anupam Sibal. I'm the president of the Global Association of Physicians of Indian Origin. I work as a pediatric gastroenterologist, and I'm the group medical director of the Apollo Hospitals Group. For those who are joining us for the first time, the Global Indian Physician COVID-19 Collaborative was established on 11th April to bring together 1.4 million physicians of Indian origin across the globe on one platform. And this happened because of the joint effort of API, BAPIO, SINS, CAPI, IMJAI, and foundations and bodies across the globe. GAPIO now has members from 50 countries. It's day 306 since the first case of COVID-19 was diagnosed. It's been reported from more than 200 countries and territories. We now have 45.5 million cases, and sadly 1.19 million deaths have been reported in India. We've had 8.14 million cases. An explosion of knowledge has taken place like never before. Till this afternoon, 69,191 papers have been published on PubMed on COVID. That really leads to 226 papers on COVID per day. 4,173 papers have been published from India. And I think with the kind of knowledge that has become available, there are many lessons that we've learned from across the globe on how to make our facilities safer, many management lessons, and I think lots of tips on patient safety. So today we're going to be discussing patient safety. We have a distinguished group of experts from across the globe. And to start the proceedings, we have none other than Dr. Narottam Puri. All of us know about Dr. Puri's work. He's an emeritus consultant, ENT head and neck surgery at Fortis and chairman of the Fortis Medical Council. He's an advisor of the FICCI Healthcare Services Committee. He's the director of Manipal Cigna Health Insurance and co-founder of Center for Design and Innovation. He has been chairman of NABH, has won several medical and industry awards, including Lifetime Achievement Awards from FICCI, the Indian Medical Association, Association of Otolaryngologists of India, Business World, Delhi Medical Association. It's indeed a privilege to welcome you. Over to you, Dr. Puri.
Thank you, Anupam, and namaskar, everyone. It's a great pleasure to connect with you all. Thank you very much. I don't think there can be a better topic to talk today than patient safety. On September 17th is the World Patient Safety Day. That has come and gone. But the importance of patient safety remains unabated. Let me just start by defining and quoting actually from the definition of WHO of what patient safety is. It is defined by WHO as the absence of preventable harm to a patient during the process of healthcare and reduction of risk of unnecessary harm associated with healthcare to an acceptable minimum. We all know as healthcare professionals that hospitals are inherently unsafe places. Hospital-acquired infections, communication gaps, wrong site surgeries, wrong identification of patients, in fact. And in fact, in 2013, there was a Harvard study of Indian patients, and it was a limited study, and they found out that there were 53,000 errors, 53 lakh errors in India. And you and I, who have worked in India for several years, know that this is a figure which is grossly unreported. And it is a figure that is difficult to believe. The real figure will be much, much higher. We are not very good at data collection, data analysis, and data dissemination. So has the time really come at this moment when we are talking of the patient and the medical community being one, and the patient's rights being respected to what he or she wants or does not want as treatment, to involve the patient and the patient's attendant in the knowledge and the prevention of patient safety and prevention of medical errors. We know that medical errors are abundant all over the world, despite the best efforts by quality professionals. But has the time come for us to let the general public know? Has the time come for us to let the patient community know that hospitals are inherently unsafe places? I know this is a very difficult question to answer, and perhaps this is not the time for us to be raising it, but surely in some forum, you do need to raise this question, because should we or should we not, should be decided jointly by those who are affected and those who are providing the best possible way to mitigate that disaster. From the perspective of, if you look at the flip side of the coin, you'll think that the litigational problems will increase, but in different countries, there are some preventive measures available. But in countries like India, you are more likely to be taken to the cleaners and the social media will be after you. But at the end of the day, as the wisdom dawns, you'll find that probably informing and being transparent is the way forward, which is what we expect from our doctors and nurses when we ask them to report adverse medical events. From the perspective of most quality professionals, I think patient safety and quality go hand in hand. They're two sides of the same coin. And from the perspective of the implementation of these measures that have been put into place by various organizations over a period of time, we have now reached a state of knowledge which allows us to do a far better job than we were able to do earlier, thanks to technology entering into the picture like RFIDs and various patient safety lists. I'm not going to go into any detail at all. My brief is small, and I'm going to sit and listen to the wide variety of opinions that a very distinguished panel, which Anupam has gathered today, is here to share with you. So along with me, do join and listen to some of the experts in the patient safety group. Thank you for having me with you. Wish you a very enjoyable evening.
Thank you. Thank you very much, Dr. Puri, for your opening remarks. We move on to our first talk, and to introduce the speaker, to introduce Dr. Kedar Mathe from IHI, we have Dr. Ramesh Mehta. Dr. Ramesh is a distinguished pediatrician from the United Kingdom. He is the founder and president of the British Association of Physicians of Indian Origin. He's the immediate past president of Global Association of Physicians of Indian Origin, has really played a huge role in defining what GAPIO is today and what we hope to achieve in the years to come. Dr. Ramesh Mehta has been recognized with the Order of the British Empire, the third highest civilian award in the United Kingdom for services to the National Health Service, UK. Over to you, Ramesh Bhai.
Thanks, Anupam. That's very kind of you. Hi, everybody. Hello from cold, rainy, windy, and gloomy England. I say gloomy because the second wave of COVID is getting worse, and there is a talk today that England, the whole UK actually, may go in national lockdown. So on that note, patient safety is very important, and it's great pleasure for me to introduce Dr. Kedar Mathe. Kedar graduated from Brown University and Harvard Medical School. He is president and chief executive officer at the Institute of Healthcare Improvement, a global leader in health and healthcare improvement. He is also a member of the faculty of Weill Cornell Medical College. Dr. Kedar worked at Partners in Health, the World Health Organization, and served as IHI's Chief Innovation and Education Officer. His scholarly work has focused on health system design, healthcare quality, strategies for achieving large-scale change and approaches to improving value. Dr. Kedar has published numerous peer-reviewed articles, book chapters, and white papers, and has received multiple honors, including serving as a Soros Fellow and Fulbright Specialist. Dr. Kedar Mate.
Well, thank you so much, Dr. Mehta, and to Dr. Sibal and to Dr. Puri for the invitation to be with you. It's a real pleasure for me and a real honor to be with this group. So let me just say namaste and namaskar to everybody around the world. Let me just start by saying a few words about the institute that I work for, the Institute for Healthcare Improvement, and before I get into the details of the future of safety specifically at this time. So the IHI has a mission, as Dr. Mehta just described, of improving health and healthcare around the world. And our vision is that everyone has the best care and health possible. And we have become, over the last several years, a leader in this area around patient safety. Since 1991, we're almost at our 30-year anniversary. Next year will be that anniversary. But in systems all over the world, in over 30 countries now, including in India, IHI has worked with large healthcare systems and in small communities throughout the world to apply quality and patient safety science to the challenges that we face today in healthcare. And indeed, we are applying those sciences to the challenge that we all experience today around COVID. IHI has three sort of main priority areas, and those are what's on the screen here. A commitment to patients, to safe and equitable and high quality care for individual patients. A commitment to the workforce, ensuring that we have not only a safe set of patients, but a safe workforce. And that will come through in just a moment as I describe one of the future directions that I believe is important to safety. And then lastly, a commitment to society. And that comes in the form of ensuring that healthcare does not confiscate the resources that are necessary in our societies to provide not only just safe healthcare, but indeed a safe civilization for which all of us, in which all of us can live and in which we can all raise our children. So those are the three areas of emphasis for us at IHI. Let me now go very directly into the question at hand, raised, I think, very importantly by what we're all experiencing around the world with the challenge of the pandemic coronavirus. So I believe there are five major future directions that we will see in the coming years in patient safety. And bear with me as I talk a bit about each one of these in turn. The first is about workforce safety, the area that I said to you earlier was going to be a factor in our thinking about patient safety. Last month, the IHI, the Institute for Healthcare Improvement, my organization, and 27 other partner patient safety organizations published a National Action Plan for Patient Safety, a document that was written for the United States, but is relevant globally and could be used with amendment and adjustment for any country in the world. That document recognizes the interconnectedness between patient safety and workforce safety, something that I think we have experienced in stark relief during the pandemic, as we have all seen. A workforce that is safe and not afraid will be capable of providing care that is safer, defect-free, and more empathetic and compassionate. The plan makes it clear that workforce safety cannot be an add-on, but or an afterthought. It must, in fact, be a prerequisite for safe and effective care. Healthcare's most precious resource and its biggest cost, by and large, is its people. COVID has demonstrated in tragic detail severe threats to the workforce, but I'm afraid this is not a new story. Well before COVID, working in healthcare has always been fraught with risks to physical health and psychological safety. And it is now incumbent on us, we believe at IHI, to leverage the urgency of this moment to think differently and to, for once and for all, rid our systems of all types of harm and give our workforces in healthcare the safety and support they need to fulfill their call as healers and to keep patients safe. Workforce safety, in other words, is a key driver for patient safety. Number two, We have to move safety beyond the hospital. We talk about hospitals a lot when we talk about patient safety. We talk about intensive care units. We talk about operating rooms and operating theaters. It is now abundantly clear that unsafe care exists well beyond the hospital. In many countries, rates of death and harm due to COVID-19 concentrate not necessarily in the hospital, but in nursing homes and in other ambulatory care settings. In such settings, incident harms are often lower in acuity, meaning they're harder to detect, but they're often more plentiful, more abundant in nature. At IHI, we have spent considerable time, and there are others on this call that have spent time researching these topics, working with colleague organizations, designing systems to detect and then to mitigate the risks and harms that occur in ambulatory settings outside of the hospital. Such harms occur not only as the result of treatment effects, but are also present in the diagnostic process, often occurring in missed diagnoses or delayed diagnoses. And importantly, harms occur with the greatest frequency, not only in care settings, but as patients move from one care settings to the next, as patients transit from the hospital to the post-acute care center, or indeed to their home. And in those transitions, there are multiple, as many of us know, multiple lapses and failures of communication which follow patients from one place to the next. Any future patient safety agenda, I believe, will address or need to address such cross-continuum safety, and we will build systems that recognize the complexity of the modern clinical enterprise. The third area is about clinicians and machines. I think we have been reluctant to recognize technologies as full clinical partners in our scientific and clinical endeavor. This builds on the work of colleagues like Eric Hollnagel and others who have studied the concept and advocated the concept of safety 2. Such safety is considered formalistically resilience engineering, and it recognizes that we, our colleagues, our patients, and the technologies we use are crucially interlinked and interdependent, and that the human contribution is inseparable from the increasingly important contribution of technologies. We see this everywhere now. In my clinical environments at Cornell, we see this everywhere. The electronic health record allows us to capture data and understand health behavior or prescribing behavior, our behavior as clinicians, far better than ever before. It allows us to detect error and, importantly, anticipate error in our work going forward. Artificial intelligence aids this process to see our own patterns. I was speaking to a surgical colleague who is experimenting with techniques today that have placed locomotion detecting chips in all surgical equipment and in gloves so that algorithms can detect and anticipate when a surgeon may make an error based on movements of hands or movements of instruments well before the error has even been conceptualized or made. Artificial intelligence will help clinicians deal with a massive information to more quickly identify required therapeutic moves, detect deterioration of patients earlier, and those at risk of adverse events. Technologies will supply us with more information than we have ever had before. And as with all such technologies, we will need to accommodate and better manage the potential downside risks of excessive access to such technologies. We have sought for too long to use technological resources and solutions sparingly, and we have believed that they contribute to increased risk. I believe it is time for us to embrace technology as a full clinical partner, no more or less important than the human clinician. Going forward, we will partner with technology, I believe, and we will extend the metaphor of the team, if you will, the healthcare team, not only from doctor to nurse to patient, but also doctor, nurse, patient, and indeed some of the technologies that we need to go forward. Clinician and machine will become full partners. Number 4 is about structural hazards. And again, COVID-19 has really elaborated a number of these concerns. My view is any future patient safety agenda will have to examine closely what we've all been living through with COVID. During this time, what would keep us the most safe as people, as patients, as clinicians indeed, would be better public health measures that would massively expand testing, case identification, and self-isolation or contact tracing. We've observed these strategies to work in Taiwan, in Korea, in Singapore, in multiple countries around the world. But I would argue in Western health economies, and I know I'm not speaking to just Western health economies here, but certainly here in the US and elsewhere in the West, rooted as we are in rescue medicine and acute care, we have largely underfinanced public health measures, which has led to an emphasis on what they do best, what I describe as rescue medicine. In the case of COVID, this has fueled the impassioned quest for the discovery of a vaccine. To be clear, I believe a vaccine will be enormously useful to all of us, but alone, a vaccine is not likely to return us to normalcy. On the other hand, public health measures will. So what does this mean for safety? In safety, we have emphasized the medicalization of safety, the direct activities at the level of the practitioner or care delivery organization, but we have largely steered clear of the classes of hazards that are deep structural challenges within healthcare as a whole. Those challenges that reach well beyond the scope of any individual practitioner or even single hospitals or even multi-hospital systems. Those hazards must be addressed at higher socio-political levels of authority. For example, no single care delivery organization or consortium can resolve the problem of look-alike medicines. No single organization can resolve the problem of enhancing the public health response to COVID, which would undoubtedly do more to keep us safe. And no single organization can solve the problem of unsafety associated with mass migration of patients due to climate change. The last area is equity, disparity, and safety. Equity is defined by the US Centers for Disease Control as the opportunity for all people to attain their full health potential. And as many know well, inequities in care and disparities are rampant all across the globe. This won't surprise any of you. Disparities are also, apart from the politics that surround them, the product of systems that vary in ways that are unnecessary, undesirable, and largely unjust. It turns out that the tools of patient safety and quality science designed to reduce variation are actually very good at identifying and eradicating such disparities and variations. And we have found in our work that the tools of patient safety, like root cause analysis and event reporting and safety huddle systems, can be applied to disparities to detect them, name them, and resolve them. So 20 years ago, with the report from the Institute of Medicine here, Two Eras Human, and other global reports on patient safety, healthcare professionals identified inequities and identified patient safety and made it visible in healthcare. We did that by naming harms. We can do that also with inequities. We measured those harms in rates of healthcare injury and infection. We can do the same in measures of disparate rates of access to care, outcomes of care, and quality of life. And then, as with patient safety, we work to eradicate those harms using disciplined quality improvement methods and patient safety methods. And again, we can do the same with inequities in healthcare. Make them clear, make them visible, and then work to eliminate them. All of this, I believe, requires us to change our perspective on safety. It requires us to say that safety is not an objective quality that exists out there waiting to be measured, but is instead an activity that is dynamically created every day by all of us as clinicians and by our patients together, moment to moment in interactions with actors and artifacts in the system. We have an obligation to study and deeply the safety sciences, and we need to welcome more research on safety and ensure that we have engaged patients and families in ways that we've never before imagined. But I remain very hopeful about the future of safety and the prospects for a health creating system that is safer than we've ever seen before. So with that, I'll turn it back to you, and thank you all for the time today to be with all of you.
Thank you so much, Kedar. Very powerful, very clear perspective on what we might see in the years to come. Thank you, Ramesh Bhai. Thank you, Kedar. We move on to our next session, and we're going to have Dr. Sudhakar Jonalagada to moderate this session. Sudhakar, our dear friend, is American board certified in internal medicine and gastroenterology and practices as a gastroenterologist and transplant hepatologist in Georgia. Sudhakar is the current president of the American Association of Physicians of Indian Origin. Over to you, Sudhakar. Unmute yourself, Sudhakar, please.
Thank you. Thank you, Anupam, for a kind introduction. And it's my honor to introduce Dr. Hardeep Singh, a professor of medicine at VA Medical Center for Innovation in Quality effectiveness, and safety at the Baylor College of Medicine, Houston. Dr. Hardeep leads a portfolio of multidisciplinary patient safety research in improving the use of health IT and reducing diagnostic errors. His research has made impact several national and international patient safety initiatives and policy reports, including those of national academies, CDC, and OECD, and the World Health Organization. Dr. Hardeep received several prestigious awards for pioneering work, including the Academy Health Alice Hirsch New Investigator Award in 2012, the Presidential Early Career Award for Scientists and Engineers from President Obama in 2014, and the Veteran Affairs Health System Impact Award in 2016. And Dr. Hardeep is going to talk today on building a culture of patient safety. Please welcome Dr. Hardeep Singh.
Thank you so much, Dr. Sudhakar, and thank you for inviting me again. Namaste all over the world. It's a great group. There's more than 300 people on this call. It's wonderful. So my job is going to be simple. I'm going to try to convince you why COVID-19 is going to be the perfect tipping point to improve patient safety. I'm going to focus mostly on safety culture and try to convince you why it's time to accelerate innovations in safety culture. So let's talk about safety before we got to COVID-19. What was the state? So Kedar mentioned To Err Is Human. This was a report which came out more than 20 years ago. So David Bates, a colleague, and I summed up the state of patient safety 20 years after To Err Is Human in 2018. And what we said was, we are still in the bronze age of patient safety. And what we need to do is to go to the golden era. And there's several things we need to do better on in order to get to the golden era. So why are we still in the Bronze Age? There's several reasons. We still are lacking a shared commitment and a shared responsibility to improve patient safety all over the world, whether it's governments or whether it's policymakers, whether it's organizations, and sometimes even clinicians. Our leaders are still incentivized to do reimbursement. Think about things like reimbursement. We are good on quality measurement, but we are still incentivized not to think about safety as much. Because for safety, you need to hardwire systems changes. We need to hardwire changes in culture, and that takes a lot of work. And there's no specific incentives in many of the countries that we know of that can promote safety culture and hardwire these changes into our work. So do we have a problem in safety culture? Yes, we do. Here's a study that we did. We asked clinicians their comfort level in discussing medical errors in public avenues. And you can clearly see that the types of errors that the clinicians are most closely involved with, diagnostic error, that's when they make the diagnosis, right? Those are the ones they are least comfortable in speaking about in any venue. And we ask them for public and private venues. You can also see that there are some hospitals that are better than others. So in this study, you can clearly see that Hospital D, the clinicians were really uncomfortable talking about diagnostic errors in public venues. And this was true for private venues as well. So we clearly have a problem with safety culture. If you can't speak about this topic freely, we're not going to get better. So what's happening during COVID-19? We've seen several negative effects on patient safety. We know that there are patients who have not sought care. Either, they had heart attacks at home, they had strokes at home. We know several patients who had chronic medical conditions that were left untreated. We've seen many unintended consequences on patient care because of the strain that we are experiencing. You can think about all the things that we do to people in the ICUs and in the hospitals, and think about line infections, think about falls, think about the patient safety events that happen now that are going to be extrapolated into a much sort of a higher level because of the strain on our medical system. So what else? Medication safety is much worse. Data aggregation is a problem. So as you know, many of the places around the world could not even tell which patients have COVID and how many in what region. So we've seen several problems with patient safety emerge over the last 6 to 8 months. So Kedar mentioned diagnostic error. Clearly, we know diagnostic error has gotten worse over time. The disease is very new. We're still learning about the disease. We're still learning new things. Imagine some of the inflammatory changes related to COVID. We only found out about them later on. Thrombosis as well. So the disease is still evolving. We're still learning about how to manage it. We're still experiencing strain and staffing shortages. So anytime there's a system problem, there's going to be a problem with diagnosis because clinicians think within a health system. They are influenced by the system around them. Compromised decision-making. Imagine you cannot examine a patient clearly, easily, if you have a lot of PPE separating them. So we've described cases where some physical exam finding has been missed. People thought patient had COVID, they clearly didn't, and a cancer was missed because nobody examined the patient. We've had experiencing some effects of telemedicine when you cannot examine patients. So again, what's happening is, and of course, everybody knows about the testing issues that have been going on around COVID. So COVID has really exposed the topic of diagnostic error very clearly. It was a problem before, it's a bigger problem now. So let's talk about the new lens that Kedar was talking about. And we never coordinated our talks, but he mentioned safety too. And I want to make sure we emphasize safety one is essentially learning from adverse events, focusing on bad things that happen in healthcare, all the harm that patients experience. But there's another concept of safety too, which essentially means focusing on what goes right. Can we learn from things or institutions or people who are doing the right things? Can we succeed under varying conditions and become resilient? So these are some things that we have noticed in the pandemic. I'm going to walk you through in the next few slides that are positive. They are short-term positive that we need to build upon. One example is changes to the way we operate in our institutions. We've had better communication between leaders at both the public as well as an internal level. There's been better communication to the staff. Some of you may have heard about a Columbia surgeon who was sending out emails, and everybody was looking forward to his email every day about a daily update about what was happening in the hospitals in New York. It was a wonderful sort of feeling getting all that news from somebody. There's more rapid decision-making than before. We have broken down many silos. The shared commitment and the responsibility that people have sort of gotten to work together, this is unprecedented. We have had very little resistance to rapid adoption of protocols. Imagine Apple and Google are working together now to try to do stuff. There are hospitals that are working together that have not worked before. There are clinicians working closely with administrators to implement protocols, whereas previously we may have had some resistance. So all that is good. What else? So I come from Texas Medical Center in Houston. And one of the things we've seen in our local hospitals, there are about 9 big health systems. Texas Medical Center, in fact, is one of the largest consortium of hospitals in one small place. It's a huge density of beds there. And all those 9 hospitals and health systems, they're usually competing for business all the time. But they gotten together and started sharing data to the public. They started sharing data about their hospital census, how many patients they have, what PPE availability they had, how many cases, how many hospitalizations, what was the state of the hospitals, together, what was the bed availability. And this had never been done before in the history of the Texas Medical Center. And all these 9 hospitals broke down all silos and started working together. And there was better communication across these organizations than ever before. So I think it's time to translate what we have been always thinking about, high reliability principles. Everybody wants to learn from aviation and nuclear power. Patient safety movement is obsessed with learning about, things from aviation and nuclear power and military. And now it's time to do that. It's time to think about, what are these high reliability principles that we can follow in medicine that it's time to implement. We need to know better about what's going on. What are the systems and processes that are going on? Oftentimes when you ask the leaders, do you know what kind of events have you had in your facility over the last year or so? A lot of the people who are in the leadership positions in the organization don't know. The board of the hospital doesn't know. We need to value more insights from the staff. They know what's going on. They know the problems. So we need to do that much better. And we need to proactively prepare for system failures. That's COVID teaching us that we need to get more proactive and less reactive in healthcare. You can be reactive, but you have to get more proactive as well. And what else? How do we make it sustainable? We've got to have more daily huddles. I mean, these are simple things that have been thought through, talked about for decades, but have not necessarily been put into practice. We need to have better transparent communication, both positive and negative effects of safety. Very important is we need to be more proactive in our measurement strategies. We need to monitor safety much better than we ever did before. So I want to give you an example of how we sort of put this together. We wrote a paper recently on learning about these short-term gains, these positive things, about fighting a common enemy. The concept of fighting a common enemy that brought everybody together to fight COVID also applies to patient safety. We need to get together and fight the epidemic of medical errors and adverse events. And what we said essentially was, everybody talked about flatten the curve in COVID. We said, let's raise the curve. Let's accelerate the curve of patient safety. Let's accelerate the innovation. So if you look at this, so diffusion of innovations is just a concept from, it's a theoretical concept where you study how well or at what rate are innovations and technology implemented within a population. And usually, there's always the late majority, there's laggards, people who don't adopt any innovations right till the end. And we said, well, there's always going to be laggards and late majority. But what COVID can do, it's a perfect tipping point to accelerate the rate of innovation adoption and innovation implementation in healthcare. And we should take advantage of that. So with that, I want to close my talk, and thank you so much for giving me an opportunity. My information is here. I'd love to get in touch with some of you. Thank you.
Thank you. Thank you so much, Hardeep. Appreciate that. Thank you, Sudhakar, for moderating this session. And that was very helpful, and the peek that you gave into what the future is going to be is most exciting. Thank you so much. And I'm sure this forum today is going to result in opportunities for collaboration as time goes by, because I think we are better connected than we ever were. Imagine we today have participants from more than 20 countries as we speak. So great opportunity there to learn from each other. We are now going to move on to the next session, and it's a privilege for me to invite Dr. Alexander Thomas. Alexander is a dear friend, a huge contribution, first as President of the Association of Healthcare Providers of India, President of the Association of National Board of Accredited Institutions. He was responsible for incorporating healthcare communication in the agenda when it came to NABH accreditation standards, and I think that's been very important for the country. And he's also the founder, president, and patron of the Consortium of Accredited Healthcare Organizations, CAHO. Over to you, Alexander.
Thank you, Anupam, and hello, everybody. Greetings from Bangalore, India. And it's my pleasure to introduce to you Dr. Neelam Dhingra. Dr. Neelam is currently the unit head of the WHO Patient Safety Flagship Initiative in the World Health Organization, Geneva, Switzerland. She was earlier a medical faculty in a large teaching hospital in Delhi for almost 14 years. Neelam heads the WHO's efforts at providing strategic leadership on patient safety and risk management within the context of improving people-centered integrated health services delivery and universal health coverage. She also coordinates WHO's work for improved patient safety and managing risks in healthcare, including global safety challenges on medication safety, leadership, safety culture, education and training, patient safety standards, assessments, research. The list is long and consists of a lot of important topics. Since joining WHO in 2000, Dr. Dhingra has been providing strategic leadership and facilitating multi-country support for strengthening blood transfusion services. So over to Dr. Neelam Dhingra to provide insights on the WHO Global Patient Safety Action Plan.
Thank you very much, and good afternoon to all of you. Thank you, Dr. Alexander, for this introduction. For the last 5 years, I've been deeply involved in the patient safety work, but my career in WHO actually started with blood transfusion safety in the year 2000. So I'm going to give you a snapshot on the Global Patient Safety Action Plan 2021 to 2030. And I must say that the action plan really marks a historic milestone in the global patient safety journey, because this is the first ever action plan on patient safety since the time the scientific and medical discipline of patient safety was born in early 2000. But the story of the action plan will be incomplete if I don't share with you the great journey and the momentum which has been generated since 2015 and 2016. And that was when an annual global ministerial summits on patient safety started. The political leadership in the UK and Germany, they initiated these huge political movement, and they recognized the huge burden of patient harm in healthcare. And that is which spurred this pioneering initiative. And there are very few areas, actually, technical areas, where annual global ministerial summits are being organized, and patient safety happens to be one of them. During 2016 and 2020, actually, there have been 4 very successful global ministerial summits on patient safety. Each year, there were more and more ministers joining. And you can see from the picture, going from the UK in 2016 to Germany, to Japan, and then in 2019 in Saudi Arabia. And 2020 actually was supposed to be in Switzerland, but because of pandemic situation, it has been put on temporary hold. But what is very encouraging is that the political leaders are fully committed to continue the summit series, and hopefully we will have the Swiss summit next year. The approach which the summit series took was to bring together the experts for up-to-date knowledge and also bring the political leaders so that they can collectively plan a way ahead and also lead to some concrete and sustainable action on patient safety. It is this movement which actually led to a hugely important year. And I must say that 2019 should actually be written in golden words in the journey of global patient safety, because at the World Health Assembly in May 2019, it was a watershed moment for patient safety. For the first time, patient safety was recognized as a global health priority when the resolution was adopted by the World Health Assembly on global action on patient safety. And it is this resolution which actually mandated WHO to formulate a global patient safety action plan to be aligned with sustainable development goals. And that's why it goes up to 2030. And this resolution also established an extremely important initiative, which is annual World Patient Safety Day on 17th September. And there are many other actions related to this resolution. So this was really the starting point for us to work together for developing a global patient safety action plan. And then you can see the picture here, and I'm really privileged and delighted to mention that several of the speakers on this panel actually have been part of this journey. One of the key steps to initiate the development of the Global Patient Safety Action Plan was to consult all stakeholders, governments, NGOs, experts, scientific community, academic community, and internally, externally, and as well as and work towards a global patient safety action plan. And I must say that the seeds for this action plan actually was sown in this particular global consultation, which happened just before the COVID pandemic was coming to the world. But this was one of the last consultations, I would say, a large consultation in patient safety, which was organized at WHO headquarters. And I'm also very happy to mention that these experts who are part of this panel not only actually were part of sowing the seeds for this Global Patient Safety Action Plan, but also watering the seeds even now to grow and develop it further. As of now, the action plan is, I must mention that the action plan, the journey of the action plan, that currently it went through a public consultation, which closed end of September. We are working on another draft, which will go for member states consultation in the month of November and early December. And this is on the agenda of the Executive Board of WHO in January. And then the action plan will go to the World Health Assembly in 2021 for adoption. So just sharing with you what actually is the action plan about. The action plan actually gives a vision of no harm in healthcare. Now, this may be debated because it is equated to zero harm. And I think this becomes very emotive when people speak about zero harm. But the vision which this action plan gives is that no one should be harmed in healthcare, and everyone should get safe and respectful care every time, everywhere. And this action plan also provides a mission and the goal, identifies key stakeholders who have to take action, like governments, all other international stakeholders, healthcare facilities, as well as WHO. And it provides 6 guiding principles and also gives 7 strategic objectives. The purpose of this action plan broadly is to provide strategic direction to all stakeholders, countries, international organizations, healthcare facilities as well, through policy action. And it provides a framework so that countries, in whichever part of their journey they are, they could develop national patient safety action plans, which are aligned to the components of this action plan, and also aligned with existing strategic instruments, which can promote patient safety in all clinical and health-related programs. So this slide actually gives the framework of action under the 7 strategic objectives, which relate to policies for zero patient harm, high reliability systems, looking at resilience, as well as human factors and leadership and safety culture, safety of clinical processes, which actually I'm very happy to mention that in the consultation, Anupam led this particular strategic objective, patient and family engagement, health workers, education skills and safety, information and research, which was led by Hardeep in this consultation and in this process. These also include the area of risk management and reporting and learning structures. And last but not least, it also relates to strategies with other programs, partnerships, and solidarity. And I must say that this provides a good overview of various elements of patient safety under these strategic objectives. The framework for action actually is under a 7x5 matrix, which gives the cohesive and holistic approach to patient safety. And it also shows its interlinkages with other health systems element, as well as also the elements related in the clinical and the programmatic areas. So it's really touching upon all aspects which have impact on patient safety and need to be acted upon to improve patient safety. Just want to show you the illustration on the structure of the action plan, that in each of these strategic objectives, we have strategies, 5 strategies. And under each of these strategies, we have actions for governments, healthcare facilities, stakeholders, which are international and civil society organizations, and also actions for WHO. And then with each strategic objective, we also have provided global targets. No action plan, as we all recognize, is really of any worth if it is not implemented. So the action plan actually provides an ecosystem for implementing patient safety, and it provides simple steps which countries could look into for assessing their gaps and practice gaps and barriers for improvement, and also look at where there has been success, where there are policy opportunities, and also get commitment from political and organization leadership, develop sustainable mechanisms for implementation, but particularly looking at the context nationally and locally, and also the priorities. And then design a model of change, looking at some upstream factors, downstream factors, particularly safety culture, leadership, and upstream factors, capacity building, and also reporting learning system, for example, and also the action plan touches upon safety 1 and safety 2 approach as well. And the lateral streams looking at advocacy and also a resource mobilization, but all this implementation has to be in the context of national and local priorities, as well as what is the capacity they have currently to implement, and also the baselining. Just to share with you, as I mentioned, that each strategic objective, we have defined some targets, and it is hoped that this particular framework of monitoring will be helpful in monitoring the implementation, as well as the trends for progress and where we are improving, where we are not improving. And in addition, we hope that the governments, international organizations, healthcare facilities, then adapt their targets to these targets, but looking at their local context and how they are suitable and which part of the healthcare journey they are, and how the systems currently at what level they are, and how they are strengthened, and what opportunities are there. So for each of these 7 strategic objectives, there are some targets proposed. And so with that, I would like to conclude by saying that WHO, as well as international stakeholders, have huge opportunity and power to shape and accelerate action on patient safety globally. And it is extremely important that cohesive and complementary action is put in place for patient safety. And the time has come that for all of us to take collective action so that we can improve patient safety. And I'm just quoting Sir Professor Puri, that we hope that there's a paradigm shift in looking at healthcare systems, hospitals and primary care facilities, where they're not seen as places which actually harm, but they're seen and they really become place where patients who come, they have trust, they are actually cured, and they also go through a healing process. So the system should heal, not harm. And that's with that, I would like to conclude. And thank you very much for this opportunity.
Thank you. Thank you so much, Neelam. Thank you so much, Alex. It was really helpful to get a peek into the plan, really comprehensive. And I know how much work has gone into it and how you've collaborated with colleagues across the globe. Congratulations, Neelam. And we're so happy that it's going to
Thank
be
you.
on. We redefine the way we look at patient safety globally. We move on to our next session and to introduce our speaker, dear friend Paula Wilson, who is the CEO of JCI. We move over to Vancouver. Dr. Arun Garg is a consultant medical biochemist at the Royal Columbian Hospital. He's the chair and president of the Canada-India Network Society. He's the assistant director of the South Asian Institute and adjunct professor at Fraser Health Sciences. Arun is a member of the executive committee of GAPIO. Over to you, Arun.
Thank you, Anupam. Namaskar, everyone, and greetings from beautiful British Columbia, Canada. It's a great pleasure and a privilege to be part of the session and introduce our next speaker, Dr. Paula Wilson. Before I do that, with your permission, and Anupam, with your permission, I want to say how delighted I am where GAPIO is and this session taking place. And I want to recognize the foresight and the vision of our founding chair, Dr. Reddy. The GAPIO will allow people of Indian heritage physicians to come together, and we will bring solutions which have a unique thinking, because we have lived in many worlds, because we have experienced different cultures. The fusion, the best of East and best of West will come together. So I want to recognize the vision of Dr. Reddy through GAPIO, and this is unfolding. With those words, I would like to introduce our next speaker, Dr. Paula Wilson. Dr. Paula Wilson, with more than 35 years of experience in healthcare industry, is the President and Chief Executive Officer of Joint Commission Resources, JCR, and Joint Commission International, JCI. JCR and JCI are not-for-profit organizations working to improve healthcare quality and patient safety in over 90 countries around the world. Dr. Paula, as president of JCI, is leading healthcare improvement worldwide through the development of international standards for quality and safety and international patient safety goals by offering domestic and international consulting, international accreditation, education, publications, and e-learning. Welcome, Dr. Paula Wilson, to give her session. Over to you, Dr. Wilson.
Thank you so much, Dr. Arun, and good morning, good afternoon, and good evening to everyone. And hopefully everyone can see the screen and my sharing. This was a challenge. I was very excited about the opportunity to be a part of this important event with the Global Indian Physicians COVID Collaborative. But I was given a 7-minute window, which is always a challenge. And so when I started to prepare for today, I started to think about how do you really express what we're trying to cope with in such a small number of minutes. And so I want to focus today on the concept of resilience and talk a little bit about that and what we're learning about that and how important that word is in the context of this pandemic. This is our mission. I'm not going to read it. Dr. Arun just really gave us a good summary of that, but Joint Commission International works out of the United States, but we do work all around the world with organizations and partnering with them to work on safety and quality and reducing harm in organizations. Most of you, I think, are familiar with what accreditation is, but we really think about it as a risk management tool to reduce harm in healthcare organizations. We use evidence-based standards based on research and scientific data. We use an external evaluation tool, a survey, to bring an objective point of view to organizations. And one of our key goals is to drive standardization of processes and procedures. We know that as the more efficient and standardized an organization becomes, the likelihood is that you're going to reduce harm. Now, it's not this simple by any means, and standards and surveys are not enough to get to a really high state of quality performance or even high reliability. But it does help organizations have an infrastructure to set up a program, a process of reducing harm in their hospitals. And accreditation as a risk management tool also helps organizations become more resilient. So what are we talking about when we are talking about resilience? The definition in the dictionary is pretty simple and straightforward. A resilient organization or a resilient human being is one that has the capacity to recover quickly from difficulties. It really comes down to the word toughness. Are you ready for unforeseen circumstances, challenges, emergencies, pandemics? How do you react in these kinds of circumstances? I think that an accredited organization is more resilient. We design the standards to help you understand where you are weak. So a part of being resilient is understanding where you're weak and taking steps to improve those weaknesses. One of the great things I think that we have to think about in terms of resiliency and reacting to a pandemic is really to evaluate how did we do in the area of imagination. I think my personal view from a global perspective and a US perspective, we lacked imagination of just how serious this was going to get and how quickly that was going to happen. I think, and we're still lacking some of the imagination of thinking about the next few months in terms of an over-optimism in some respects. Resilience really requires us to be imagining things that are much more difficult, much more challenging than what we have done so far in this pandemic. But we do understand that as we work on things like accreditation, looking at processes, looking at our procedures, we can become more resilient and have a better capacity to react to these kinds of emergencies and challenges. COVID has certainly been the ultimate test of resiliency for healthcare organizations and to some extent for JCI itself. I'm really proud of how we've been from a resilience perspective. We really quickly adapted to some of the challenges of the pandemic. On March 13th, we closed our offices, and I'm proud to report that that following Monday, that was a Friday, we went back to normal business. So we have built in resilience in terms of how we do our work to be able to react to this kind of circumstance. We are now easily doing virtual and hybrid surveys around the world. We're pretty much back to normal, and we're back to normal as early as July, but it took quite a bit of work to, again, showing our resiliency. We understood the importance of Zoom, what we're using today, the amount of staff training that went into getting ready for that. We adapted very quickly and very smoothly, which is another characteristic of resiliency, is being able to react and come back strong, to be tough, to have a backup plan so that you're ready for unforeseen circumstances. We also, and I hope you'll take a look at our website, have been producing enormous amounts of content, just our own content from the Joint Commission in the US, from JCR and from JCI. And we also became a curator, as I like to call us. So we also gathered a lot of information from organizations all over the world and curated them and also put those on our website so that organizations, whether they're accredited or not, can go to the JCI website and find a lot of materials about how to cope and deal with COVID and how to improve care in organizations going through this pandemic. So final thoughts in a 7-minute presentation. One of the things that I think is important from a resilience perspective is also learning from everything that's happened so far. So we are looking now at how did we do as an organization, as an accreditor? How can we do better in terms of making organizations more resilient? We will also be studying our own organizations, the accredited organizations that we work with, what worked well, what didn't work so well, and how do we learn from that? And then making new recommendations, perhaps changes in the way we do our surveys, the way we write our standards, are all likely outcomes as we react to the pandemic and get ready for the next problem that we know now is only likely to happen again. How do we ever imagine that this could not happen again? So I want to thank everybody for the opportunity to speak today and to talk about resilience as a patient safety issue, and really evaluating your ability as an organization to react to challenging circumstances that are unpredictable and extremely, extremely difficult to get through from an organizational operation perspective. Thank you very much.
Thank you. Thank you so much, Arun. Thank you so much, Paula. A brilliant presentation and sharing your thoughts on resilience. And I would like to compliment you and your leadership and how you have navigated JCI. We've had firsthand experience on how a virtual accreditation happens when our Proton Cancer Center was accredited. And I think over the last several months, we've had the opportunity to see how you've adapted and how flexible you've been in terms of embracing technology so that the accreditation work continues, and you've continued to support all the JCI accredited hospitals across the globe. So a big thank you to you, Paula.
Thank you, Dr. Spal. Thank you very much.
We move on to our next talk, and to introduce Dr. Kocher from NABH, we have Dr. Nandkumar Jairam. Dr. Nandkumar Jairam is a well-known surgeon, a minimal access surgeon. He's the CEO and chairman of the Columbia Asia Group of Hospitals. He served as the chairman of NABH. Dr. Jairam is the vice president of Capio. Over to you, Dr. Nandkumar. Over to you, Dr. Nandkumar.
Yes, sorry, I was muted.
No problem, please.
So thank you, Anupam, and it's a pleasure to introduce Dr. Atul Mohan Kocher, who got his MD from the Delhi University and currently is the Chief Executive Officer of the NABH. He is also the current president of the Society for Pediatric Dermatology and founder secretary for the Scientific Cosmetology Society, and has held various organizational positions like the president of the Indian Association of Dermatology in the Delhi branch and so on. He's been the recipient of several state and national awards and has more than 70 publications to his credit. Quality, promotion of patient safety, and taking best healthcare practices to the poorest of the poor are his missions. Dr. Kocher.
Thank you so much, sir. Thank you for such kind words. Thank you, Anupam. Thank you, Capio. It's been a wonderful experience listening to such esteemed, distinguished faculty today. I mean, I am only going to build up on those, what has already been said in the next 5 minutes odd, which I have, but patient safety and quality and the NABH experience. And primarily, I'm here to introduce NABH to this huge audience of 350 plus from 20 plus countries. NABH stands for National Accreditation Board for Hospitals and Healthcare Providers. It is, if I can very simply say, the Indian equivalent of JCI, because JCI, as Paula said, has been around for 70 plus years. And NABH is a young 15-year organization, restless, and we are a teenager now. So thank you so much. Prior to 1997, the concept of quality in any domain in India was very, very fragmented. I mean, we had Bureau of Indian Standard, we had the measuring department and other things. But frankly, the Quality Council of India brought in the culture of quality, the starting of quality, a beginning was made. And Mr. Adil Zainul Bhai, the chairman, the current chairman, and the chairman is appointed by Honorable PM. And then we have a Secretary General, currently Dr. R.P. Singh, and we are an autonomous body under the Ministry of Commerce, DPIIT. There are 5 boards. NABH is one board which looks after the hospitals and healthcare providers. We have a lab board which has done human service during the pandemic called NABL. We have an education and training board called NEBET and a certification body. Then we have a whole lot of divisions and project things which look after various ministries. So all these are the ministries which we cater to, and primarily each one of our board is benchmarked to the best in international quality, like APAC. For healthcare providers, we have ISQA, and just like JCI, we are also benchmarked against ISQA. These are certain other bodies where we work, and our Ayush mark and our traditional work, our Z. These are various projects which have done some excellent work over the past years. This slide is the key important thing which gives us a snapshot of the range of NABH activities. Over the past 15 years, currently, we have managed to create and implement standards in 21 broad areas which are there, subdivided into 3 broad categories of accreditation, certification, and empanelment. So we have today programs under various headings, and we are very proud to say that currently about 9,600 hospitals of various categories and shapes are currently partnering with NABH. We work with the Ministry of Ayush to benchmark all the Ayush hospitals, and we are soon coming up later this month in the November month with entry-level Ayush to cater to 12,500 entry-level smaller Ayush setups also. Then we have various excellence programs, and this has been the journey so far. This is the certificate, for the ISQA for the 5th edition. So currently we are into the 5th edition. And again, NABH is a true embodiment of the self-reliant Atmanirbhar Bharat, the homegrown standards which are already there in the 15th year. So this is our proper standard book, the guidebook, and the standards which are there throughout. This is the 5th edition, and that's the certificate. And post-COVID, we also showed some resilience by adapting and switching over, and in consultation with Paula, who was a great help, and we learned from them, we learned from the best in the world, and moved on to all our processes. We moved on to virtual setup. So we are continuing with that. Not only that, I would here concur with what Dr. Hardeep said, that this pandemic has shown us that the only way to handle or tackle such pandemics, or in any case, to move on to a good quality setup, is by sharing. So in that spirit, we launched our Quality Connect initiative. This was launched in April, and already more than 15,000 people have logged on to our site to learn with us, to share our resources. And we did about 150 plus webinars led by master trainers who on every topic. And not only that, in the spirit of the freedom, from 15th of August, we revamped our website, we revamped all our processes, and we made all our standards free of charge. Earlier, there was a nominal charge for all these standards, but currently all standards are freely downloadable and free of charge from our website. So this is not only that, we are maintaining a resource center which is upgraded real time, and all our webinars, all our trainings are uploaded on our website free of charge for everybody to download and see in their free time. We also initiated work on digital health standards, which is first of its kind in India, in the world. And this digital standards propose to cover all important concepts of information, privacy, security, and interoperability, which are built around the National Digital Health Mission and framework of National Digital Health Blueprint. We are working on a backbone of FHIR, HL7, FHIR, and these are free resources which are soon give meaning to so much of telehealth which is going on. I would encourage everybody to see these our website, visit our website, and learn from and guide us further about how NABH can take part. I would also here concur with what Dr. Neelam Dhingra, madam, mentioned. And if we are to heal and not harm, if we are to take quality, ecosystem of quality, or create a culture of quality, if we are to reach out, then we must we have to reach out beyond those islands of excellence which we have managed to create over the past decade and a half. So over the past 15 years, NABH has partnered with, let's say, 9,600 various hospitals. But keeping it in perspective, there are already more than 1 lakh hospitals, and there are not only these small hospitals. If we are to reach out to people beyond these boundaries, reach out in tier 2, tier 3, tier 5, tier 6 cities, then we have to reach out to people and tell them about the basics of hand hygiene, basics of communication strategies, basics of surgical safety checklist. And the only way is when we reach out to them and tell them and share our resources. So keeping that in mind, NABH is founded by forefathers like Dr. Nandkumar Jairam, Dr. Girdhar Gyani, Dr. Narottam Puri, who all have contributed in making this a very strong organization built upon the strength of probity and propriety. So thank you so much for this opportunity. Once again, I will encourage all of you to visit the NABH site, and thank you for this opportunity. Thank you.
Thank you so much, Dr. Nandkumar, and thank you so much, Atul. Appreciate, Atul, you thanking Paula for the support that we've had, and just shows how COVID-19 has brought us all together and how we've learned from each other. It's been an experience learning from each other. We now move on to the anticipated Q&A session, and we have all our experts. And to introduce the 2 moderators for the Q&A, we have Dr. Lalu Joseph, doctorate from Canada and management degree from IIM Bangalore. She is the quality manager of Christian Medical College, Vellore, a very respected institution of medical learning and clinical care in India. She is a principal assessor of NABH and is the current Secretary General of CAHO. Over to you, Lalu.
Good evening, and I bring greetings from the Christian Medical College, Vellore, and the consortium of accredited healthcare organizations. It's my proud privilege to introduce my mentors, Dr. Vijay Agarwal and Dr. Girdhar Gyani. Dr. Vijay Agarwal is currently the president of the consortium of accredited healthcare organizations, CAHO. He was the advisor to Max Healthcare and co-chairman of the accreditation committee of NABH. Dr. Agarwal is an excellent organizer, strategist, and administrator, and over the last 4 decades has played a key role in impacting the state of healthcare in India. He played a pivotal role in driving national programs such as Pulse Polio program and introducing centralized waste management scheme in Delhi. He was the chairman of the Nursing Home Forum of Delhi from 1992 to 2002, and he is also the recipient of the Lifetime Achievement Award of Indian Medical Association. And about Dr. Girdhar Gyani, he is the Director General of Association of Healthcare Providers of India, AHPI, which is working for building capacity in Indian health system through advocacy with Indian government. AHPI provides education to the healthcare providers with focus on making healthcare safe and affordable. Dr. Gyani was Secretary General, Quality Council of India, an apex national body responsible for establishing and operating national accreditation structure and promoting quality in all areas of healthcare. Dr. Gyani has been instrumental in establishing NABH with global recognition, bringing patient safety and healthcare quality in the forefront in India. Over to you, sirs, for moderating the Q&A session.
Thank you very much, Lalu Joseph, and thanks to Anupam and Gapio for bringing such a wonderful session to the viewers. I tell you, this session should have been for 2 hours because we are given such a short period of time for the experts. So what we are going to do, I think time already we have gone ahead of time. So me and Dr. Vijay, I think I have kept 3 questions, and Dr. Vijay also will have 3 questions. So let me, I think, leave the question for quality and accreditation to Vijay. And let me ask one policy question to Dr. Hardeep Singh. Because he mentioned that patient safety has not got that kind of importance. Everybody is talking that millions of medical errors are happening world over. Why the patient safety is not in the focus of the policy makers or the people who are in the power? Dr. Hardeep Singh. Can you answer this question?
That will take another 2 hours, sir. But in short, you know, there's two things. One is there's extrinsic motivation or external incentives, and one is intrinsic motivation. I think as a healthcare industry, we're all intrinsically motivated to make sure that we deliver the best possible care and we do the right things for the patients. What happens is the external incentives get in the way. So the way we are paid to deliver healthcare, the way we get our salaries, the way we get reimbursed, the emphasis is still on the volume of patient care and the procedures that we perform. If we can take the focus away from, you know, pushing things onto, you know, sort of from quantity of patient care more to quality of patient care, I think that's the way to go. For that, we're going to have multiple changes. We're going to have to change the way we reimburse healthcare. We're going to have to figure out how to reimburse quality and safety better. Why isn't the CMO or the CEO of the hospital more accountable for patient safety? There is no reason. Why is it not on the agenda item for the board of the hospital to listen to all the medical errors that have happened? So all of those reasons, I think, and I can go on and on, but I got to stop.
Thank you very much. And my second question is to Dr. Neelam Dhingra. You see, WHO has got the excellent curriculum on the patient safety, but I actually am in touch with the Asian and the ASEAN countries. You know, I'm on the board of some of them. I do not find this curriculum being formally taught in the MBBS curriculum in all these countries. Why it is so?
So thanks for that question. Actually, the curriculum has been developed in different phases. The first one was for medical professionals. The second, which was launched in 2011, was for multi-professionals. Yeah. And we are now going through a new sort of wave of updating the entire curriculum. But there have been many challenges actually on implementing the first time. And we actually did a survey as well, in which we had 30 countries who really took it up and implemented across the educational system. But many others faced challenges, particularly because of capacity to train and teach. So with this resolution, which I mentioned, which really becomes now a foundation for future work, there is a huge emphasis on capacity building. So we are actually, the objective we have put to ourselves is developing a safe, compassionate, and competent health workforce. Of course, health worker safety is very, very important for that. But compassion and competence are the two things which we are focusing on when we are developing health workforce. And so point taken. And I think in your capacity, if you can promote healthcare institutions, education institutions, academic bodies to incorporate that in their curriculum, it will be great. But we are soon bringing in a modular way each topic separately. The first one we started working on was medication safety. And the second one we are working on is general approach to patient safety. But then each topic is going to be reviewed and updated. So over the next, I would say 1 year or so, we should have the new curriculum guide as well.
Okay. And my third and last question is to my friend Kedar Mate. You see, I want to know why we have not been able to encourage our physicians and surgeons to do peer review on each other in the same specialty, same HOD. You know, we find this is lacking. Can Dr. Kedar Mate throw light on, with the IHI effort, how this can be promoted and encouraged?
Oh, thank you, Dr. Gyani. It's a pleasure to see you again, and once again, to be with everybody here on this conversation. I think that peer review is going to be a bigger part of our future. I mean, it only makes sense that institutional peer review occurs almost never at this point in time. Individual peer review occurs sometimes haltingly and insufficiently. But I think this is the time for us to think about how we can do that. Surgeons do that occasionally with review of cases in different surgical subspecialties. But in many instances, if we can adopt, I think notionally the concept of professionalism and individual autonomy interferes with our ability to actually provide guidance and advice to each other as individual practitioners. And at an organizational level, what we have found is that the ability for us to collaborate and to share best practice and knowledge across institutions has been impeded by a sense of competition, particularly locally. And I think that kind of local competition interferes with our desire to create more collaborative type learning agendas that can further our effort going forward. But I strongly believe that technology enhances our ability to communicate with one another. And I think as we start to move individually and institutionally, we will start to see more of this kind of interaction across and within discipline across peers going forward. So I look forward to more of that, because I think that is at least part of the answer to a more distributed concept of safety that happens in real time every day in every interaction.
Hey, thank you, Dr. Kedar. Now I hand over to Dr. Vijay Agrawal to raise.
Thank you, sir, and thank you, Anupam, for allowing me to be a part of this very illustrious panel and gathering. My question is to Madam Paula Wilson. Madam, we look at United States in many ways. You have been in that country for 70 years now. And even after 20 years of the Institute of Medicine report, the United States medical errors continue to be the third leading cause of death. So what do you think you are going to do differently to change that scenario? Or is it that accreditation may not be just the right vehicle to bring about patient safety?
Unmute. Thank you for that question. And I think some of the other participants have gotten at some of the answers to that question in terms of where are the incentives, where are the rewards. But I think it also takes a major change in the way, and we know after 70 years that accreditation will take an organization a long way. And it's been interesting to look at hospitals with JCI, especially. We are still every year accrediting close to 100 hospitals that have never had any kind of external evaluation. So we know that if you've never been accredited and then you get accredited for the first time, your performance goes up dramatically. But then it kind of levels off. And this is true around the world, in the States as well. And we hit a certain level of performance that is better than what it used to be, but it doesn't necessarily drive an organization to the state of high reliability. So we know that hospitals in the States and everywhere, accreditation helps enormously, but it does not take you to the state of zero harm, which is what we are talking about at the enterprise of the Joint Commission. And we talk about it in terms of three aspects: that you have to have leadership, that, and we're talking about, Dr. Singh mentioned, are leaders properly incentivized to work on this? Because right now there's much more of an incentive to perform financially than there is from a patient safety perspective. But a leader would create a culture that is transparent, that is just, that is learning, that is reporting. Because what happens right now is traditionally in healthcare and hospitals around the world, we have a blame culture. So if there's a mistake, the person who was the unfortunate employee, a nurse or a doctor, who made a prescription error, for example, the blame goes on that individual, as opposed to taking a step back, collecting the data and understanding what was the process that is broken and how do we fix that process. But we don't know where the process errors are happening because we have a culture that is blame and not one that is celebrating reporting and transparency, and no punishment if you do report that a surgeon is making a mistake, for example. Nurses that are comfortable reporting when physicians don't wash their hands, and all of those things that we're all familiar with. So we're working on this at the Joint Commission, at the enterprise level, at the JCI level, is just building in some of the concepts of high reliability into how we do our surveys and standards. And there is an emphasis today, unlike before, on leadership. And leaders create a culture where reporting is much, much more encouraged. And then you understand where your issues are and how to work on them and improve the processes. But we know this takes a very long time, And quite frankly, we have not had a rush to participate in some of this work. There are some free tools that we've made it available to do, to look at your different kinds of things like infection control. We have a new one on sepsis, but it's a lot of work to attack these kinds of issues, and people are busy with many other things, and so sometimes patient safety and quality does not take on the level that it needs to in my country and in countries around the world. But we know there are ways to get better at this. We know what the tools are. We know it's about leadership. It's about safety culture, and it's about reporting and working on the processes. And I think that there are some moves in the United States from a government perspective, because they have so much influence here, to doing some of that more. But I always ask the question, why does it take an accreditor or a government or a regulator to drive this? How do we inspire the leaders of individual hospitals to do this on their own? You know, we're all leaders on this call. Many of us run organizations. You know, you have to feel the drive yourself as well as in order to improve the capacity and the performance of an organization, and not wait for someone to tell you to do that. That's the other challenge.
Thank you. I think the point that you raised, and that is again a very important point to ponder, is that we have to learn from the mistakes. And the problem is that we don't talk about the mistakes.
Right,
and the reason
exactly.
the reason we don't talk about the mistakes is that you are bashed up, first of all, in our country, of course, directly by the community, of course, by the media, and that you are absolutely afraid of litigation. I want to understand that how can maybe international bodies like WHO, Madam Neelam Dhingra, how can they advise the governments that you cannot have media trials of the medical errors, even when you already have a lot of alternative processes of just to bring justice. The issue is this, that single thing is killing the opportunity to learn from the medical errors. So has that been a part of WHO in terms of their advice to the governments, madam? I'm speaking this to Madam Neelam Dhingra.
Thank you so much, Dr. Agarwal. So this is the bread and butter of WHO. WHO works with member states, all governments, all ministries of health, and the most important approach or the core function of WHO is evidence-informed, evidence-based advocacy. And this advocacy doesn't only come from WHO, it comes from all international stakeholders and national stakeholders. Most important element, I would say, which brings about change at national level is national data. So if you present national data, what is the scale of harm and where the risks are, where action is required, that is what will make a real difference. The international instruments such as the World Health Assembly resolution is a very important advocacy tool as well as a policy level tool, which through which WHO asks countries to prioritize patient safety. And I'm very happy to mention that when the Global Patient Safety Action Plan is being developed, we have actually asking countries to report on this for next 11 years. So the document which is going to the executive board, which will be hopefully made publicly available soon, that actually asks that WHO should collect every 2 years data on progress on implementation of this resolution and the action plan. And we collect data from member states, from international partners. So every 2 years, we are mandated to report to the World Health Assembly till 2031. So this, I think, follow-up from WHO will also be extremely important for countries to prioritize. But I would say that ongoing advocacy is extremely important, and also showing the linkages with other global commitments which governments have made, particularly universal health coverage and sustainable development goals, where countries are showcasing their successes. And I think there's a huge opportunity there to show that how patient safety is very much central to universal health coverage. And when we are improving access, if we cannot improve access to unsafe care, because we want more and more people to come to healthcare facilities and seek care. And if the services are not safe, people will not have trust in the system. So linkages with the national commitments, national initiatives, and also ongoing advocacy based on evidence, which is local and national evidence, I would say key ingredients to bring about this change at the policy level. Thank you.
Thank you. My request still will be, Madam, to please include this as a part to, I would say, as your advisory to the various governments to start the non-punitive culture of healthcare in every country so that we are able to learn from the mistakes. My third question is to Dr. Koch. Yeah, thank you. My third to Dr. How, sir, you are going to think about promoting the culture of safety in our country, as you all, probably we all understand that people are hankering more after the stamp of accreditation rather than the real intent. And somewhere along the line, I think even economics, even the poor reimbursement by the government itself may be killing the whole movement of patient safety. So what are the steps, or do you think that is an important consideration for you, or it is only the numbers of accreditation hospitals?
Thank you so much, sir. I mean, as a founding father of NABH, I mean, that's an excellent question coming from you. You are very correct. Initially, any organization, I mean, in a wide and diverse country with wide geographic and economic variations, it's only natural that initially the hospitals may hanker after the stamp or to hang the certificate on their wall. But once they start once they get enrolled into the program, once they start seeing the outcomes, as Paula also mentioned, that they are accrediting about 100 plus new hospitals which have never been accredited. Once they start entering the system and see for themselves the benefits, the non-tangible benefits, the improved outcomes, the improved staff behavior, everything, then they start really imbibing the culture of quality. And I would here also again concur absolutely with what Dr. Hardeep said, sir. I totally and absolutely concur what he said, that this pandemic has forced us to introspect. And introspect, that only way we can move beyond is if we move beyond the boundaries of excellence into the far-flung corners of our country and make people sensitized. I mean, they have to know the basics of hand hygiene, the basics of communication, basics of surgical safety, basics of patient safety goals. If we are to even take a small step towards universal health coverage or sustainable development goals 2030, then we have to reach out to these people, to reach out to the last man in the line. And our accreditation is a very small step towards that, by sharing our resources, putting everything in the open domain and encouraging them to come out. I mean, whether it's an intrinsic motivation or extrinsic motivation. So that's a fantastic question. But I truly believe that by reaching out to people, by telling them the true benefits of accreditation, as you are doing, sir, as for so many years, I mean, in various capacities, we have seen that CAHO is doing various capacities, NABH is doing, and all of us are doing, and GAPIO now is doing for so many years. So once we reach out, people will listen, log on, learn from each other, our best practices, and they'll see the importance of imbibing the culture of quality. Thank you so much.
Thank you very much. So back to the organizers, to Dr. Anupam.
Thank you so much.
Over to you.
So much, Vijay, and thank you so much, Dr. Gyani. On the chat, we've had some very exciting questions, and some ideas really in terms of what is it that we can do about protecting the healthcare staff from some of the reactions that we've seen happening. Sadly, even during the COVID times, when doctors have really and healthcare workers have put their lives on stake, and in India, more than 400 doctors have passed away fighting COVID. There's also a request from the nursing community on how we should be able to develop a program where we engage more actively with the nursing community. They play a stellar role in patient safety and quality improvement, and I think that needs to receive the kind of attention that the nursing community has received in the West, and that's something that I think we all in India need to make that as a part of our agenda. I think it's been a fantastic session. I really want to place on record the time that we've had from the faculty. Absolutely world known for their work in patient safety and quality improvement. Their leadership is well recognized. And I really want to thank the faculty from different parts of the world and India, and of course to our delegates from 20 countries who've joined. Thanks ever so much. Have a wonderful Sunday. Till next month, till our next GAPIO collective session. Bye-bye.
Thank you. Thank you.
Thank you.